overview. As usual, if you have any question, please, you can send it to me. Ask me any questions and I'll reply to any question. Please, when you send a question, you can CC your batch leader so that when I reply to all, and this is, it will help maybe others. Now, what are the drugs used in Parkinson's disease? Now, the outline, it's the overview of Parkinson's disease, approach to Parkinson's disease management, clinical use. I was having the pharmacokinetic, and then I believe, even I removed the pharmacokinetics from the Alzheimer, by the way, drug. Mechanism of action, side effect of drug use in treatment of PD. Now, as you know, Parkinsonism shares symptoms found in Parkinson's disease and other causes. The major problem of Parkinson's disease is Parkinsonism, even with other causes that causes, the major treatment or the major medication that I will deliver today is mostly regarding how to treat Parkinsonism. Now, remember, Alzheimer is related to what? To acetylcholine. So we are giving what? To increase the acetylcholine. Those are the medication to help the Alzheimer. What about the Parkinsonism? Do you know what's the major neurotransmitter that we need to replace it? Let me see if someone will answer me. Dopamine. Okay. So now it's very good. Remember that dopamine is the most important in what? In Parkinsonism. So dopamine, remember, you have from the synthesis, remember from POD, the synthesis, their storage, they're acting on the receptors, or so you have, I'll bring for you one of the pictures. So you will have medication that will act at different stages of L-Dopa. And also, because it's an imbalance between dopamine and acetylcholine, sometimes they will give what they will give. As it's an imbalance between dopaminergic activity, which is an decrease in dopaminergic, and increase of cholinergic activity. So you have to decrease the activity of muscarinic receptor and increase, but mainly we need to restore the normal dopamine. Now, this is the sign symptoms. You have to remember it all the time. Resting tremor, bradykinesia, muscular rigidity, postural instability, and impaired speech. By the way, it can happen because Parkinson's disease or due to others, mainly antipsychotic drugs. Did you take the antipsychotic drug? Because this is one of the major side effects of the antipsychotic drug. No, not yet. Okay, so let me tell you, whatever you're seeing, these are Parkinsonian. You will hear about the haloperidol, one of the antipsychotic. They will cause Parkinsonism side effect. Now, the possible causes, not everyone who has Parkinsonism has Parkinsonism. Not everyone who has Parkinsonism, it means he has Parkinson's disease. There are many other causes of Parkinsonism, which we call them secondary Parkinsonism, including medication, which is mostly of the antipsychotic, brain lesion, or Lewy body dementia. I'm sure, let me tell you, I will not be asking, but I'm depending on the consultant that they are the one who will tell you, or who's ever covering pathophysiology to tell you more about the Parkinsonism. Now, pathology of Parkinson's disease is caused by progressive deterioration of nerve cells of part of the brain that control muscle movement. So as you see from the picture, is more related to muscle movement. You will have degeneration of the substantia nigra fall, okay, region in the midbrain. Now, the major one, you have to remember it, loss of dopaminergic neuron, where in the Alzheimer is loss of acetylcholine. So you have loss of dopaminergic neuron in the substantia nigra with 60-80%, which is we call it their cholinergic hypothesis, here the dopamine deficiency. So we have to replace the patient with dopamine, but here it works, at least in Parkinson's. If you give them dopamine, at least maybe at least you can find some improvement in the patient. Acetylcholine surplus, which is excessive, likely cause of the dyskinesia. Now remember, just this one, I don't need to know the blue and pink and like this, just I found this one from dopamine, remember it goes. So remember, if we give them dopa, remember, if you remember, it will be converted into dopamine in the stores, and they have to be stored, and then they have to be released to act on certain receptors, and then you have they'll be metabolized by COMT and MAO. So now if you want to give medication, can someone answer me from the steps I already mentioned them? What do you think certain medication could be covering? The step I mentioned them. Can somebody answer me? You have from dopa, storage, acting here, and you have the metabolism.
Maybe COMT inhibitor
Great.
or MAO.
COMT inhibitor, MAO inhibitors. Okay, this is one category. Another one. To give them the L-Dopa. I don't know, somebody is answering in the chat. Dopamine transporter. It's related to dopamine transporter, but it's more you want to deplete those storage to let them to be released. And then you have certain agonistic. Somebody is answering. Levodopa, right? More precursor, right. No, you have to have more storage. You want to have storage so that will be released. Because if you have less storage, you have less dopamine in the vesicles. Okay, so you have, if you try to empty this one and to have them to release to act on D2 receptors, and then, or you have certain dopaminergic agonists. So at least you know 1, 2, 3, major one, and the fourth one is related to muscarinic. Dopamine reuptake inhibitors, no. Yes, it's a good thinking, but we don't have. Yani it's mostly them. I will mention them now. I put them for you. Let me tell you how I put them for you, really in an easy way. The pharmacological one is, as you see, dopamine precursors, like someone have mentioned. But you need, with the dopamine, I put number 1, the decarboxylase inhibitor, and I'll explain it for you why. Then you have the dopamine agonist. Remember when they should act on the receptors. And then we said COMT and MAO. And again, we have the NMDA. The NMDA here, they act as dopamine facilitator from the storage. And then last one, the muscarine. So the major one is, which related to the steps I already mentioned it, precursor, agonist, MAO inhibitors, or their metabolized inhibition, and the NMDA antagonist. Don't ask me, I will tell you how it will help. To have increase in the dopamine, okay? And then you have the muscarinic antagonist. The non-pharmacological, usually they need support group, speech and language therapy, and occupational therapy. Let me see if one of the chat, to inhibit decarboxylase. Yes. Do you know why? Mariam, can you answer me why do we use decarboxylase? Because really, this is very important. We cannot give dopamine precursor alone without Carbidopa, which is the DERBA. Answer me, but not in the chat. I want to hear your voice. To cross the brain.
I remember we give Carbidopa with Levodopa, and Carbidopa inhibits decarboxylase in the peripheral nervous system, so that the Levodopa does not convert to dopamine in the peripheral nervous system and crosses the blood-brain barrier to the brain.
Great.
And dopamine there.
Okay, great. So you wanted to cross the blood-brain barrier. Okay, great. Do you think now some of it will act the dopamine in the periphery? Can we all convert it or not? It's very important to understand those because you will know the side effect. Do you think all the dopamine will be converted? But we want to synthesize dopamine, so why we are inhibiting the carboxylase in the periphery, Bushra. We're talking about the periphery, not in the central, so that they will cross the blood-brain barrier. Because if you want them, okay, let me explain it before you get lost. Now, this is the treatment strategy. As I put it for you, number 1, replenish neuronal dopamine by supplying levodopa, which is a natural precursor, levodopa, but you need to give it, remember, with decarboxylase inhibitor, which acts in the periphery, not centrally. Act as dopaminergic agonist, which is the bromocriptine and why I'm not pronouncing well, pramipexole. Let me tell you, one of them is ergot, one non-ergot. The ergot is this one is replaced by the ergot, okay, bromocriptine. Prolonged action of dopamine through selective inhibition of its metabolism, the COMT and MAO-B. We're talking MAO-B and not MAO-A. I hope you still remember the MAO-A, which is we have the entacapone and selgelene. And then we have the release of dopamine from stores and inhibit the reuptake, which is by amantadine, which is an NMDA receptor. I will explain it for you how. And then decrease the discrepancy in dopamine and acetylcholine. Since we have a big discrepancy, we try to give antimuscarinic drug. Now, let me know, this is the first one where it acts the TOPA. You have to give them the L-Dopa. The second one, which is the agonist, where you want them, they act on the receptor. The third one to inhibit those MAO and COMT. Remember the MAO-B and not MAO-A. And fourth, which is the storage of the dopamine. I will mention all of them in details. Now, the treatment strategy, as remember that we have an imbalance between dopaminergic neuron and excitatory cholinergic neuron. So mainly, so the mainly medication from all what I mentioned is the levodopa and the carbidopa. These are the main one. You want to increase the dopamine and to decrease acetylcholine in the central nervous system. I never seen people they're using it, but it's there. Maybe, I don't know, some consultants use, but mainly I know the L-Dopa with carbidopa will be mainly used in Parkinsonism. Now, the main treatment approach, as you remember, more than 65, we give them levodopa plus the decarboxylase inhibitors. I'll mention it why we give them together. If it's less 65, sometimes they give them dopamine agonist, COMT inhibitor, or MAO-B inhibitors. Now, the L-Dopa, which is levodopa, it's a precursor of dopamine, which will be converted by dopa, a decarboxylase in the presynaptic neuron, which is a direct dopaminergic effect, which has a direct dopaminergic effect in the D2. This is a central effect, okay? So the most effective for sympathomimetic treatment of Parkinson disease or Parkinsonism even. So because it controls the bradykinetic symptoms. Now, the first line of treatment, more than 65 years, the major disadvantage is extensive decarboxylation of levodopa to dopamine in peripheral tissue if you have it, because this is what I asked you, the one who she answered me. If you have in the peripheral tissue decarboxylation of the levodopa, what will happen? If you don't do it, like, it will not reach the blood-brain barrier, but that's why we need to use peripheral decarboxylase inhibitor. But at the same time, remember, when you are converting it to dopamine, it might go and act to we have the blood vessel and heart rate. So that's why we use the carbidopa, but in the periphery and not in the centrally. This is the topa decarboxylase usually. Now, the decarboxylase inhibitors, these are carbidopa. Usually the most commonly one that I heard about it, the carbidopa. There is the benzerazide, which I found it in Ambos, but usually what I see in King Faisal, let me tell you, is the carbidopa. They block the dopa decarboxylase. They decrease the peripheral conversion of L-Dopa to dopamine. So what will happen? It will go and cross the blood-brain barrier. Therefore, it will increase bioavailability of L-Dopa, which really passes blood-brain barrier, unlike dopamine. But still remember that you might have certain amount of dopamine that acting in periphery. Decrease the peripheral side effect of dopamine, which is the orthostatic, because it goes to blood pressure, nausea, vomiting, and also the heart. I mentioned it maybe later on. So always they are given alongside with L-Dopa to reduce sinus symptoms, but does not stop progression of the disease. They decrease sinus symptoms, but they never stop progression of the disease. Now, these are the formulation. I put it for you, honestly, because it's important. I see in many questions it will come. What are the carbidopa to levodopa? Usually, the carbidopa is 25, where the levodopa is 100, or 25 to 250. This is what I see in the hospital, and we call them Cinemet. It's intermediate. We have Cinemet, sorry. Intermediate release tablets are available, as well as extended release tablets. So this is the most important medication to be used in Parkinsonism, is the Carbidopa-Levodopa. You have different combination, 25 to 100, 25 to 250. 25 is the Carbidopa. Usually I see people, they use either this one or this one. Now, what is the levodopa side effect? Usually autonomic, nausea, vomiting, orthostatic hypotension, or tachycardia. It's reduced by what? Giving the carbidopa, because you don't want the levodopa to be into dopamine and to be acting periphery. So you're trying to avoid this one. Usually motor fluctuation like dyskinesia and dystonia. Usually L-Dopa should be withdrawn gradually to avoid severe akinetic crisis, which is a complete inability to move or incomprehensible speech. And usually those should not be stopped abruptly. Or usually these patients are taking care of their family, and they'll be giving, no one will come and stop it abruptly. Now, the side effects of it, it's hallucination, insomnia, agitation, and depression. Now, the drug-drug interaction, usually we have to be careful not to give vitamin B6 because it increases peripheral conversion of L-Dopa to dopamine. We try to avoid it. Antipsychotic usually are dopaminergic antagonists. If you take the antipsychotic, you remember these are dopaminergic antagonists, and thus counteracting the L-Dopa effect, because you want the dopaminergic receptors are ready to act on it, the L-Dopa. Now, tricyclic antidepressant may aggravate even the hypotensive symptoms. There are other drug-drug interaction, but I took the major one, which is the vitamin B6, antipsychotic, because these are dopaminergic antagonists, and because they can cause hypotensive, so that's right, they might be aggravated with tricyclic antidepressant. Now, I finished the first one. I put it for you. This is the first one. Now, the other one, which is acting as dopamine antagonist, we have non-ergot and the ergot derivatives. As I tell you, we have the pramipexole, which is acting more on the D2, but is more efficient on D3. I'll not ask you this question, but mainly we're looking to act on the D2 receptor, and bromocriptine acting on the D2. We're not using any more bromocriptine. The pramipexole has superseded the bromocriptine. Both of them, they act directly at the striatal dopamine receptor and do not require enzymatic conversion, so we don't need dopamine, okay? They control bradykinetic symptoms mainly. Usually, their first-line treatment for patients less than 65 years old because of the fewer motor side effects. It can be adjunct for patients of all ages with advanced PD, and if they're not responding to, let's say, levodopa and carbidopa, they might add for them dopamine antagonists, and remember, should not be stopped abruptly. Now, their major side effect, dopamine agonist withdrawal syndromes occur due to abrupt discontinuation, which is rarely you can see it, like clinical feature hyperthermia, rigor, akinesia, renal and liver enzymes. And usually, and I don't see it so much because those medications are given by the family. They should not be stopped abruptly. Now, the others, which is the same as the L-Dopa, which is the autonomic, when I mentioned the nausea, vomiting, orthostatic hypotension, it could be psychiatric or motor. And motor is less frequent, but the nausea, vomiting, they might have it like the L-Dopa. Dopamine agonist ergot derivative, as I mentioned for you, have been largely replaced by non-ergot derivative due to rare but severe complication, including the ergot. They might have fibrosis, cardiac fibrosis, Raynaud's disease, pleural pulmonary fibrosis, and retroperitoneal fibrosis, as you see, in all types of fibrosis. So the ergot is not anymore used, which is because it's replaced by non-ergot. Now, okay, the second one, we finish it. Now, we need to prolong the action of dopamine through what? Inhibition its metabolism, either by the COMT or the MAO-B. Remember the MAO-B, not MAO-A. We have the MAO-B, which is the entacapone, acetylcholine, which is the COMT. The COMT inhibitors, I put for you entacapone and tolcapone. I put for you in green entacapone later on, because usually tolcapone, and I see usually entacapone because there is a combination, which is Stalevo, which is levodopa, carbidopa with entacapone. So, and it is more important to me to remember entacapone. They inhibit COMT, which is catechol O-methyltransferase, one of the main enzymes which is responsible of metabolizing the dopamine. So we have more prolonged action of what? The L-Dopa. It's ineffective as monotherapy, always administered as combination with Carbidopa-Levodopa, which is this one I mentioned it. Entacapone is most effective with patients with early and dose deterioration or wearing off. And let me tell you, some of the patients, by time they don't respond to Carbidopa-Levodopa, so they try to add for them some other medication. Tolcapone usually is used also in refractory Parkinson's disease as it acts on central and peripheral COMT. But honestly, what I see it's mostly used is the entacapone. Now, the MAO-B inhibitors, which is Celgilene. Remember there we have MAO-A. Remember the MAO-A? Can you remember MAO-A from POD? I don't know if I taught you this MAO-A inhibitor. We cannot give them with certain antipsychotic because they do hypertensive crisis. Just try to remember in MAO-A, which is, it's not found in the MAO-B inhibitor, in the side effect. So it's a selective MAO-B inhibitor in the CNS centrally, responsible for metabolism of dopamine in brain, which retard breakdown of dopamine in the CNS. Sorry. It uses alternative to L-Dopa or dopamine agonist for short-term therapy in patients with mild symptoms in early disease stages, okay? Or we can use them, so we can use them as monotherapy if it's early stage or combination to decrease, usually for motor fluctuation. Usually after prolonged therapy of L-Dopa and Carbidopa, up to 5 years, disease control become poor, so usually we add the MAO-B, which is the Celgilene. Now, the major side effects, nausea, headache. This is which is more important. Remember, they don't cause hypertensive crisis because if you're ingesting tyramine-rich food, remember when I told you about tyramine-rich food? I don't know if I have given you this lecture that it will be causing you hypertensive crisis. This one is seen with MAO-A and not MAO-B. It's a nice question to ask you, huh? MAO-A and different from MAO-B. Please review the MAO-A inhibitors, how they are, cannot be given with any food rich in tyramine because they can cause hypertensive crisis. With the MAO-B inhibitor, you don't have this side effect. Now, okay, there is one question. After Proncter, we add MAO-B or Celgilene. Wallahi شوفي Bushra, let me tell you, what do we add? You have to ask the consultant and what their preferences and what they see. They can add one of them depending on the patient. Is it better this one or this one? Usually, what I see, there is the entacapone. There is one medication that will have all the three medication, which I mentioned it already, the Stalevo. Or they might, to me, it's better to give one medication that have all the three, which is levodopa and dopa and entacapone, rather than to give them two medication. So depending on the preferences of the consultant, if you have it both medication at the hospital, so which is better, honestly, I don't know. I have no idea. This is what they will decide, usually the consultant, and how the patient will respond. Now, I hope I answer you, Bushra. Doctor, for this block, what drugs do we need to cover again from POD? Just only Iman, just only the MAO-A inhibitors. لأنه important to compare it. لأنه really this is, it will goes and everyone will ask you about MAO-A inhibitors and why we cannot give it with people they're eating food rich in tyramine, because it can cause hypertensive crisis. I don't know. Somebody answer me? Did anyone? Did I give you this lecture, or you cannot remember? And well, I cannot remember to whom. With the corona, I cannot remember if I give you this in POD. Yes, yes. So remember when I told you, if people, especially the European or American, لما بيروحوا they go, they drink glass of wine, or they're taking MAO-A inhibitor, which is one of, is it antidepressant or antipsychotic? You have to remember. And then they will, if they drink or ripe cheese. Remember I told you they eat a lot of ripe cheese and they drink a lot of alcohol, so they might go into severe hypertensive crisis. Alhamdulillah. If somebody remember, yes, yes, yes. Sarah, thank you. Yes, okay. Just read this one at least for your own to compare between MAO-A and MAO-B. And well, it's a good question to ask you. Oh, it's a good revision for you to know what's the, yani if giving a patient MAO-B does not put him into a hypertensive crisis, where if you give him MAO-A, he can be into a hypertensive crisis. Now, before the last one, release of dopamine from stores and inhibit reuptake. Now, the NMDA, that the one we mentioned them in the Alzheimer. Now, let me tell you, these are antiviral, okay? I didn't mention in the Alzheimer. We call them here dopamine facilitator. How they increase the dopamine release, do not ask me. How they will inhibit dopamine reuptake, will leave them postsynaptically, honestly, I don't know. The mechanism is not fully understood, but the researchers suggest that activation of NMDA, these receptors, which is an excitatory neuron activated by glutamate, may be a causative factor in generation of striatal neuron. But at the end, what they are seeing, that there is an increase of dopamine, which acting on a different receptors. Or you have, you inhibit the reuptake. Some of you, they asked me about the uptake. Am I right at the beginning? If you inhibit it or you increase dopamine, so you have more dopamine to act on the receptors. How, yalla, be happy, is not fully understood. Okay. Now, the last type of medication, which is still in the Amantadine use, is a drug of choice during a kinetic crisis in abrupt stopping. If somebody he stopped L-Dopa, they will give it to them, or to reduce L-Dopa induced dyskinesia. And I read too much. When I put in green, it means I read it in up to date or in AMBO, so I felt it. No, this is an important that you remember. You have to study all the lectures, but when I put in green, it means really these things you should not leave semester 4. You have to remember those. It has a slight antimuscarinic effect. Is relatively free from, let me tell you, slight antimuscarinic. They believe in a relative free from side effect. Still they have ankle edema, orthostatic, insomnia. I don't know if it's free from side effect, hallucination, prolonged QT. But I think these are rare. Since I did not highlight them in green, it looks they're really rare. Rare side effect. Fine till now. Are you okay? I'm about to finish for you the lecture. Now the last one, which decreasing the discrepancy in dopamine and acetylcholine. They believe that if you give antimuscarinic drug like benztropine, usually their mechanism of action to inhibit the excitatory cholinergic neuron, decreasing the concentration of acetylcholine centrally. Okay. Researcher. Okay, this is theoretical, and researchers suggest that decreasing the acetylcholine proportionally to dopamine improve the symptoms. I don't know if they will add this medication along with Carbidopa and L-Dopa. If the patient is responding well, I don't think so. They will add for them the antimuscarinic drugs, honestly. Because this giving them, it's more helping them in tremor and rigidity rather than L-Dopa and Carbidopa. It's better to, the most important and first line treatment is L-Dopa and Carbidopa. But it's used as monotherapy in patients less than 65 with tremor as the main symptoms. If they have tremor only, they might give them this antimuscarinic. Now, they avoid it in patients in more than 65. You have to remember it also this, because they are more prone to anticholinergic. Remember anticholinergic side effects, urinary retention, constipation, and dry mouth. I don't know if I give you this. And also if they have prostate hyperplasia. So if you have urinary retention, if they have prostate, that's why most of the above 65 years old male, they have this prostate hyperplasia. And if you have urinary retention, you are worsening their case. So that's why you avoid them in more than 65. They are given in less than 65 only for in case of they have only tremor. I think it's the last one, this one. Yes. So any question, guys? Thank you, Doctor. Thank you, Hanof. Thank you so much. Please, if you have any question, if something you miss it, you can always email me. Don't worry about my exam. I think you should know me by now. In semester 3, my exam was direct, which usually I mentioned while I'm giving the lecture, or I put it in green. And usually I'll give the main mechanism of action, major side effect, major things that really I want you to remember it. Sarah, تسلمي يا Sarah. والله, I wish you best of luck. I know it's not easy to have this online classes. I hope that at least you memorize my lectures, at least Wallah, let me tell you, Wallah, it takes me time to prepare your lecture. I read from up to date, from the book, and from the AMBOS. I know what's clinically is more oriented, that you need to know it at least when you go to clinical rotation. So I hope at least you remember or memorize my lectures. يعطيكم العافية, مريم. I wish if I know you on campus. I don't know whom I know, whom I don't know. ليش البنات بس اللي they are thanking me? وين الأولاد؟ شكل الأولاد they left, right? والله يعني بحسها it's my pleasure. عبد الله وأخير عمر. Thank you عبد الله وعمر. Somebody. Best of luck. Go enjoy your time until 3 o'clock. Have lunch. Enjoy your time. I'm always there.